All right, welcome. We'll go ahead and get started with documentation dismemberment. Beginning with disclosures, we have none, as usual. Objectives, it's a little different flavor of documentation dismemberment here. We will be focusing on adult wellness visits and the requirements for those, and doing a side-by-side dismemberment, which is a little different than before. So last time in March, we talked about wellness visits and what all went into that. So I thought it made sense to dig a little deeper into that and how we can build wellness visits, not just on Medicare, because I think most people are thinking Medicare when they think wellness visit, but you can actually bill wellness visits for other insurances as well. Medicare, unfortunately, like everything else CMS does, is heavily regulated and has very specific requirements. And if you don't meet those requirements, then you don't get paid. There's different types of wellness visits under Medicare. You have a welcome to Medicare, you have an initial annual wellness visit, a subsequent annual wellness visit, and the well woman visit. Not going to get into all different pieces of what those are, but obviously welcome to Medicare is your first year that you have Medicare, which could be your initial, but it could not be if you don't get your initial for 2 years after you have Medicare. So once again, very cumbersome requirements and regulations.
65, right?
Yes. For now. It won't be by the time we get there.
80.
70 at least. So all others, so Medicaid and commercial insurers have wellness visits, codes that they will pay for, but they don't really have specific guidelines, and there's just some general recommendations. So it's much easier to get wellness visits in that. I did not go so far as to dig into the money side of all this, but that's something I think is worth pulling in at some point and discussing. But we're actually going to get into how you can get both. And I think that's where the money's at. So from a Medicare wellness visit standpoint, the main requirement is a health risk assessment, the HRA. It's required for every Medicare wellness visit. At minimum, must include demographic data, health status, self-assessment, psychosocial risk, behavioral risk, and an assessment of ADLs and IADLs. A lot of that is really just questionnaire type stuff with the patient, but there are some requirements to actually do get up and go test and those kind of things to see how well they can function. There's actually a totally set of the requirements are not completely different, but there's two delineated requirement sets for initial versus subsequent. The biggest difference there is that depression risk and functional ability assessment are not specific requirements of the subsequent, but they are in the initial. Now, interestingly, I think this is where the money comes into from our view standpoint. You can't bill acute or chronic or acute on chronic issues as part of the wellness visit, but if you actually in one note can document both were accomplished, you can bill both codes at the same visit. So that's where the potential to generate revenue exists, is to get paid for the preventive stuff and then get paid separately for managing a problem, or just get paid for preventive stuff if that's all you did. So the document that I received for the actual specific requirements for initial and subsequent AWVs for Medicare was 7 or 8 pages, because each one of these is a heading in there that's about, it was more than 7 or 8 pages, because each one of these is a third to a half a page of details to go along with each bullet point there. So there's a lot that goes into that. Subsequent, as you can tell, is not really different. So with an initial, you're just establishing all this stuff, whereas with a subsequent, most of it is just reviewing what you already put in there. But number 5 and 6 on the initial, the potential depression risk factors and the functional ability and level of safety, was removed from the subsequent requirements. So the subsequent's exactly the same, except number 1 is review and update the HRA that you did in the initial. Removes those two And that's how you go from 13 down to 12 bullet points. Otherwise, it's really just updating what you've already done. With the big part that I think we tend to focus on when we think of prevention is number 6, which is update the patient's written screening schedule. That's where you really get into the colonoscopies and mammograms and pap smear part of any of this, which is surely at Medicare age, we're not having to do pap smears, but I'm sure there's if you got a certain history, you're still getting pap smears. Any questions about any of that? So how would, if you were trying to set this up in a clinic, like how would you do that?
Seems like you would want all the questionnaire stuff done prior to them, you going in the room and seeing them.
Exactly, and that's
We would have the nurses, update the family medical history, all of this stuff, and actually do most of it.
yeah. So the key is to have a nice outline process,
Yeah.
bullet by bullet for the nursing staff to do before you ever.
Because all of this could be
Synchronization.
done by them. You don't.
So that's what Medicare intended. None of this was intended to actually have to be done completely by the provider. Now, I mean, you're probably going to want to get involved in the written screening schedule when you get in that. You're going to have to order the mammograms and the colonoscopies or colorectal cancer screening, whichever they choose in that. Depending on how you set things up, nurses can actually do some of that by protocol already if you've got those protocols in place. So you really could automate this entire thing.
Yeah, you just go and say
you
hi,
just
do
go
the
up.
exam.
Say hi, do an exam and something off on it,
Yeah.
which is where I think there's a revenue potential there because you can do a lot of work that requires small physician input, and the RVUs are pretty good on Medicare and the wellness visits. I don't know about the commercial non-Medicare one. So for non-Medicare wellness visits, mostly we're thinking this is a lot of what we're already doing anyway with preventative care, lab screening, test, immunizations. One of the key parts to really both, but particularly to non-Medicare wellness visits, because they so seamlessly flow into what we already do, is stating that it is a preventive visit, it is a wellness visit, because it's hard for a coder to just catch on and go, oh, this was a wellness visit, unless you actually delineate that. Chronic conditions, you can address chronic conditions, and if nothing really needs to be, if you're not really doing anything other than refilling meds, you can only bill that just underneath your wellness visit code. You can't do a separate E&M code for that one. But if you have acute conditions or an acute on chronic issue where you're having to manage the blood pressure because it's out of control, then that can actually be billed as a separate standard E&M code. So that's where I think now you're getting the bill for 2 different visits in one visit because you're doing the work. So that's where I think there's a lot to be gained and do it well.
And another thing would be, like you said, you need to mention somewhere that has like Medicare visit or the welcome visit, right? So by then the nurses should have also mentioned that. So when we go and we already have a dot phrase, which brings all of that out, and just along the same thing. I mean, if they're filling everything, because we do all this, but we don't know if it's the first welcome to Medicare visit, if it's just a regular follow-up, if it's, and so if just adding that one term and we're already doing all the work, then it helps to be able to bill for that.
Yeah, I mean, you definitely have to have a good process with clear auto text.
Yeah.
And know exactly what the nurses were documenting and how that flows into your documentation to capture everything. Unfortunately, what they do doesn't always flow well into our notes.
So does that health risk assessment have to somehow be copied into our note? Because it's completed separately as an ad hoc. So what happens then?
It's a good question that I don't know the answer to, but I'll ask the coding gurus to see. They did not mention that in any of their communication with me, so I'm assuming if it's in the chart, they can still take it and bill for it. I would think so, because if it's there and it's dated, it's timed and signed, they can defend it
Mhm.
without having to actually pull it in. That would be my inclination, is that there wouldn't be a requirement to put that in there. But I think it's nice to have just a clean auto text that says, I did all this and I reviewed it. Because the key piece is that you reviewed it.
Yeah.
And you're attesting to that. So like I said, we're gonna go side by side. Dismemberment here, so I've pulled up, got two examples. All the stuff on the left column is going to be one note, and all the stuff in the right column is going to be the same, all under that same note, so left versus right here. So from an HPI standpoint, what are you thinking, just in the compare and contrast between these two?
I think on the one on the left definitely mentions that this is a wellness visit to start with, but it also, the age is 48, so. No, never mind, I don't know what I'm saying.
Oh, no, Medicare, well.
Yeah, I was like. Then I looked at the age. And
It's very concise. She's doing medication.
Yeah, there's some interesting statements in it, for sure. All about the typo or the patient issue, I mean, it looks like a typo, but
It definitely.
Dragon would never leave it uncapitalized.
Yeah.
It'd be capital.
This is typed. So, I mean, I think it's not amazingly written, but it talks about the mammogram. Talks about the colon cancer screening, vaccines, active blood pressure, skin is also always part of that. And then I guess doing medication, not sure what else, but yeah, the left one is definitely covered it. The right, although barely talks about anything, or maybe it's also written in the assessment plan because it says chronic conditions as described below.
Yeah, so I mean, while it looks like something I wrote on the left, because it is pure, no punctuation, no capitalization, just bullet, boom, 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 boom. Everything is like,
Yeah.
so ruthlessly efficient. And it's not mine.
Does it need to be there though, if it's talked about with the nurses and all that?
Well, if it's not an annual well, so this gets into what's your process for that. Because Medicare stuff is has clear forms and stuff, and you don't know. If it wasn't done by the nursing in that process, then you would have to actually knock that out. If you're tagging it on to something else you were doing, or you just converted a regular visit into a wellness visit because there wasn't much else to do. And that's where it's kind of a good usage of it, because you can probably get more out of it than just doing the standard, what looks like it could be a 99213 here, low level code. Because you're just sounds like we're just refilling some meds and nothing exciting is about to happen. And on the right, yeah, there's not, that HPI doesn't tell us much at all.
She's in his current state of health.
Yeah.
He is how he is.
Yeah, so getting back to the last talk where we had a very similar HPI that was stretching it to try to get a 214. You gotta be concerned of, are you really gonna have enough in this HPI to justify anything else you do in the rest of the note, so.
And also, I mean, I think what they mean is that he's in his usual state of health. Because his current state of health could be bad.
I mean, your current state of health is always, I mean, it's always a true statement.
Yeah.
True. I am in my current state of health right now.
As mine.
This very instant. Now I'm in a new current state of health. That instant passed.
Noted.
But chief complaint has more information here than the HPI, so. Well, maybe this see below, this as described below will save it. All right, so moving into histories. Which will, I guess, better define the current state of health. Anything exciting? Anyone there?
I think you could definitely get a 2-on-4 with both of these, just going off conditions and medications.
Right, so there's a 214 just sitting in here with very little effort. So moving in, so here's your review of systems physical exam.
Let's use good dog races.
Got that foot exam in there
Yeah.
for diabetes.
I don't like the skin exam on the left.
Yeah, can go. Covers.
But if you say no rashes and somebody takes that to court, they're gonna ask if you, basically, if you got them naked head to toe. The best you can say, unless you're getting the patient completely naked and you are checking behind their ears and all those things, is no rashes on exposed skin. That's a medical legal thing that
Thanks.
it's pet peeve. A soapbox, if you will.
I think both are pretty sufficient, pretty thorough.
I mean, just nitpicking, it seems like they use the exact same. And just, it's almost like they're almost nearly identical auto texts that have been. Had some tweaks to the formatting with the underlines and the. Because H-E-N-T, but it's actually H-E-E-N-T, because they both address the ears and the eyes.
No, they're separated out.
Yeah, but it's H-E, there's eyes there, but then no sclerolicterus is in the H-E-N-T.
Oh, for Pete's sake.
You see what I'm saying? It's whoever they stole that from had the same, it's the same base auto text from.
Well, now that I know it's there, it's bothering me.
So on that foot exam. Love that as the diabetic foot exam.
No,
Didn't go into the.
monofilament.
It has nothing to do with monofilament, which. to
And
me
that's the main
says
is,
you
that's,
didn't even think, what was the point in even doing it? If you
Yeah.
didn't
And
know?
it doesn't say, I mean, because you can say diabetic foot exam.
They just wanted to look at the feet.
Some people are.
I mean, maybe, but I'm just saying, if you were really trying to do a diabetic foot exam here in state, that you even did one, then I would not call that kosher unless they use the form and it's buried somewhere in the chart. Which is why I don't like to use the form, even though the form makes sense to use, but if you can't tell you've even done it, then what's the point in using? It's an awfully big physical exam. I guess it's a wellness visit, but there's not a requirement even a wellness visit to do this head to toe extensive physical exam, so. Seems like a lot to do. Are you really looking? My question. I have my doubts. All right, so moving in assessment and plan. Yes, the one on the right is cut down because they put every single order under every single diagnosis. So I snipped them. To make it easier to look at this rather than have one slide for the left side and then 5 slides for the right side.
Well, there's a lot more information on that than there was in the objective. Like they went into what they talked about.
This note is the right. It is a good written, it is a well written note, I'd say.
All of that I would have put in my HPI.
All that I put in the assessment plan. The only thing I could say is the left is repetitive. It's the same thing he wrote in the HPI wrote under the well adult. Oh, now it's discussed and ordered, I guess.
The part about could not tolerate trulicity secondary to nausea is the part that I would put in the HPI. Because you're saying at the very beginning that one of the chief complaints is not an intolerance to a medication, and then it's not even mentioned in the HPI.
Right. Which, will this work? Sure, but it's just making life difficult if you're a coder trying to look at this and put together, do we even have an HPI here? I think that one sentence probably saves the whole note because it technically is HPI. But if your coder isn't thinking outside the box at all, I might dig some HPI out of one bullet point in the assessment plan. You could easily get this whole thing tossed as a, what is a doable note?
Though it's an improvement is that goal.
Any thoughts on that? I mean, I have a lot of things to nitpick here.
I don't love it, but I don't know why, other than there's things in the assessment and plan right that really needed to be in the HPI.
I do like that the BMI and the A1C are at rest in the assessment plan on the right.
Those parts I like, and clearly there's a dot note on the diabetes to let you know all the things that you're doing in your assessment and plan every time, which is like, what's their A1C, what was it before, what meds were they on? Have they had a, dental, eye and foot exam? That's a good, complete, like, yes, these are all the things this patient needs to do, and we looked at them all.
It doesn't seem like the one on the right is a wellness exam. I don't think anything in there was addressed like colonoscopy.
PSA is about the only thing.
Yeah,
So that's,
I didn't put it in the problem list. I don't know if you have to, but
yeah, this looks like a regular visit. How do you feel about the foot exam done 11/22/23?
what date is it right now?
Not in 2023.
Oops.
It's this month. I think it's where you gotta be careful. So then that's causing the question, was the exam copy and pasted from another note? Or did we really update the foot exam and then just forgot to update the date here? I don't know. But just looking at it, knowing the date of service is not that, makes you wonder, where in the world did this come from? I'm not a big fan of starting all this stuff about Monjaro in one number and then having it continue down the other one, but with actually more. It was like it was an incomplete thought in number one, and then it gets completed in number two. That makes sense. Stopping through listing and starting Monjaro, but then down here, well, if they can't, we're gonna change Monjaro, but if they don't have it, we're gonna do Ozempic. Seems like you would.
Put all
package
that together
that.
and then say
Yeah.
plan is above.
because if you're doing a plan for morbid obesity, why were you, I mean, Trulicity works, but it, to me, it's not, you're managing diabetes. So put it all under your diabetes when Trulicity doesn't even have an indication for obesity by itself. I may be nitpicking, but it seems like there's a lot of time spent having to copy, paste, edit something that says in two different places, you got half of it there, half of it there. But like you can say it, from a not a wellness visit, it's a decent assessment and plan. You're just trying to build it. Well, yeah. Go to that point, I don't know why we're at gold and increasing in medicine, but I think the blood pressure is 120 something.
You can be at goal, but harder.
Yeah, it's round trial.
More better.
60 years old.
Yeah,
More better.
If it was the 48-year-old that's on the left,
yeah.
I could understand pushing the goal. Pushing it.
And it also says the microalbumin creatinine ratio not elevated, because if that was, you could argue,
You could-
you know, doing an ACE or ARB. But I
Well,
don't know.
and then you'd have to argue that doing a higher dose ACE or ARB was better. And
Yeah,
it's
so-
not exactly support. And CBD is in there.
yeah,
That's a lot of stuff in there that I'm
Yeah.
not sure what it gained. If they're diabetic or diabetic 60 years old. I don't know that I would even spend my time.
You already got the indication.
I'm only gonna do a CBD risk in there if I'm trying to not put them on a statin. It's so pretty obvious that they need one. What, I mean, what are the chances that a diabetic isn't gonna end up on a statin? It's pretty low. So,
that's it. Unrelated, this is the dot phrase for ACVD pulling all the data. We still have to manually calculate with the apps.
you still have to manually calculate with an app.
Okay.
So I mean, the time spent to calculate that on an
Input
app
all that
to
is,
tell
yeah,
you information that
Yeah.
is not relevant.
that's fair.
It's pretty inefficient to me.
Yeah.
ASCVD calculator is a great thing,
Yeah,
but you need to do it every time on a 60-year-old diabetic
if
with
we were,
hypertension and hyperlipidemia. I mean,
yeah,
we could. We don't need an app to tell us that's a problem.
if it was like a dot ACVD and was able to put everything and give it to you, then it makes, yeah, then you could just do that.
If this 48-year-old over here was a diabetic with just hypertension,
Then,
they might be on the borderline, whether they approve of the statin or not. Depending on philosophy about statins. All included. 7 point, they're still using the 7.5 cutoff. But whether you can go without it or not. But some people just stick with, if you're diabetic, you get it. And move on with life. I think this is really just a bunch of prescription refills. So a lot of stuff refilled on both sides. Corrections, future orders. Like Ethan's point, PSA is the only screening test order in this whole thing.
Maybe they were good on the colonoscopy, but just what never mentioned.
It was in the histories that they had one done in 2019, so maybe, but it wasn't
Explicitly stated.
really stated. So does that really capture, well, did you really address it if you didn't discuss it? It would be hard to me to justify that you addressed their wellness if you didn't explicitly say not do or something. especially when everything else looks like. All right, so left versus right would either qualify as an annual wellness visit.
No. The first one didn't mention that there had been a health risk assessment done or that it was reviewed or mentioned in any way.
So it counts Medicare.
Mhm.
But they're 48, so I think they could count as a.
Sure.
The right, any way in which you could stretch the right one to annual, to be a wellness visit.
Be tough.
There was no mention of that anywhere to start with.
Wellness wasn't even one of the problems. I think that makes it hard too, if you're trying to justify that code or.
Yeah.
What do you call standard E&M code for addressing an acute or acute on chronic condition?
Yeah.
Acute on chronic on
This side.
Okay.
Yeah, so the right side clearly has got, I mean, that's an easy 99214 right there. You got an acute, you got a chronic condition, not a goal, change the medication, boom, done. You can document just that, out of 99214. All right, so why or why not? Well, and then, so I think we kind of covered that. What could you turn the right side into an annual wellness visit or to a wellness visit? And what would that take?
I don't think he mentioned anything about screening, did he?
just PSA, that's it.
Yeah, there was nothing about, I didn't even see if it was a male or female, but there was nothing about colonoscopy.
Yeah, I think if you
Yeah.
just
If you're
maybe
getting a PSA on a female, that's a problem.
Oh, that's fair, yeah, should have. Yes.
talk about the age appropriate screenings and then put it in your problem list that you're doing a wellness visit.
Yeah,
I think that would suffice.
I mean, I really think you could have turned it into a wellness visit
and in
by just
addition,
saying wellness visit,
yeah,
not due for colonoscopy.
yeah. Very easily, and then
And
bills
put
for,
your PSA down there. Like it's that simple to have turned this into a wellness visit. And then, because then you have also had, you're also managing all these other issues.
key problems, you could have gotten us
You
to,
could have actually double billed 99214 and the wellness code.
because the right one definitely seemed like he, put in a lot of effort doing that, and you could have easily done. Yeah.
I feel like there's a lot left there. But any chance you could make a standard E&M code out of the left one?
Yeah, I think down at the bottom, they mentioned something about hypertension. Well, there was
A little bit maybe.
Yeah, it will be tough. Like, I think by the rules, maybe. But all it says is hypertension. There was a bunch of other problems back in the histories that might have been tagged in there. And even some things that were ordered. That probably, like, there's a lot more orders there that address things that are not in the assessment plan.
Mhm.
So have hyperlipidemia, or I don't know what that CBC is about, other than it's for a well adult exam. Yeah, insurance gonna cover that. Unless if there was some anemia history, tagged anemia, you're actually checking a lab for that. You might have gotten a 3 or potentially a 4 out of checking labs that don't really, like, there's nothing preventative about a CBC or a CMP. So to tag those to the well adult exam. That makes sense. I think did the patient have hyperlipidemia? Might even, lipids are tough. Lipids can be a screening thing, depending on how often they've been done. And you've been better off tagging it to morbid obesity. lipids tagged to morbid obesity, you might.
Mhm.
be able to
Diabetes.
fly.
Maybe.
Or they don't have, the left side didn't have diabetes, just hypertension and morbid obesity. But if you could tie the lipids back to something else, that you're actually a reason to screen.
Could you warrant like a A1C if you tagged it to obesity?
I don't think they cover that
No,
from the
'cause
insurance standpoint.
if you get a basic or a comp, you're gonna get a fasting. And you can get a fasting for a lot cheaper.
Which is the thing, the guidelines for it state you should screen them. But it does not specify that A1C is the only way to screen. So the insurance companies are not gonna pay for it usually. Because you're gonna get a basic or a CMP for something else.
Yeah.
Get a bunch more information. And if they don't have impaired fasting glucose, you've done your screen. And you've not spent money on a singular test.
Gotcha. So maybe you could do the obesity and the CMP.
Yeah, I would try anything other than well adult exam because none of that's gonna get covered except that mammogram. For what's tagged with orders. So which type of insurance do you think you could get that wellness visit covered for?
Non-Medicare.
Which it was, I think they were Anthem. The one on the left was Anthem. They were both commercial, both of them were commercial payers. Definitely could get the wellness visit out of the one on the left, the one on the right. Needed some work to get there. That's why it's sent to me as good example, bad example. Any questions, comments?
I should have known what a Medicare wellness visit was 3 years ago.
So when we do them in here, they always tell us, don't try to address any chronic problems because then you can't bill it as a, annual wellness visit.
Yeah, that's not true.
Okay.
Even
We
for
were told,
Medicare.
we were told that at one point. I already questioned it, Medicare, specifically the coding people. You can still bill two separate codes in that video.
Hmm.
So now why we were told years ago, when we started it, probably 8-9 years ago, when we started annual wellness visits, that you couldn't do anything other than the annual wellness visit. I don't know. Have the rules changed? I doubt it.
So it's probably just somebody read too far into it.
I think it's all a little bit, I mean, as we always say, it's all in the eyes of the code.
So would it then be your wellness visit code plus 99214?
Yes, with some sort of modifier that I'm not sure which one it is.
And can we do that? Like as residents, can we?
We have to have a preceptor see them because
Yeah,
Medicare,
anything that's not a 992030405 or 213-214-215. Actually, no, I don't think you can bill fives without that. I think
you
it's
can't bill four for
I think
that.
it's just-
I don't
It's 2, 3, 4 and of news and established. That's all you can bill without a free, no, 2 and 3, sorry. Yeah, so no, you only have this very narrow scope of what you can bill. It's just something when you get out into practice, you can think about how to capture more. With some easy tweaks,
Yeah.
you're not gonna get a lot off these because you can only do it once a year and making sure you capture it. My thing is, does the patient? I always worry too, that if you're doing this more as a wellness visit, but then you actually bill them for something that they're actually going to pay for, because most of the stuff is zero cost these days. Let's say you do, their blood pressure's high and you change a med. Well, now you're gonna bill them for it. So I think that's where you also have to be careful. The patient knows it's they may get filled.
Mhm.
We need to.
Especially if you schedule them for a wellness visit and they think that's free.
Yeah.
I think that's some of the catch to why
Mhm.
it's tricky to do both.
It's better to kill them for the wellness visit by itself.
No, it's not, because then you're gonna have to do 2 visits, which is gonna take up your time. It's more efficient to do them together,
Right.
but you have to be very careful that you document it such that you take care of both pieces of documentation. And then that the patient knows. They're not gonna get billed for a wellness visit. Or that they'll get billed for 2 separate visits. To me, if they're on there for a wellness visit and you say your blood pressure's under control, I think it's fair to say your blood pressure's high, so I'm gonna take care of it, but that's gonna generate a separate bill. It's still easier for them than coming back to see you next week. They're already here. You can just say the rule, and that's where I think they probably misconstrued what we should be telling people.
Mhm.
Instead of telling them they can't get it done and then make them come back. We should have been saying, listen, the rules say I have to bill you for a second charge if I take care of this blood pressure issue. Or I can see you back. We're both here. We know there's a problem. Let's go ahead and fix it, but you are gonna get the second charge. For the same, you're gonna get 2 charges for 1 visit. But I don't like to send people out of here with a problem and make them come back just because of Medicare rules. You just blame Medicare. They'll blame Medicare and life will go on.
Mhm.
Take better care of the patient. Medicare takes the blame for doing, for actually, because that's the way the system's set up. So is it really blame or just truth? But wraps it all up.